Mhm. Hello, Rita. Sounds like you're coming in on audio.
Hi, this is Rita.
Rita, nice to meet you. How are you doing?
Good, good. How are you, Dr. Gish?
Doing okay. Are you working from home today?
I'm off today. Start a stretch tomorrow.
Thanks for coming in on your day off for this discussion.
No problem. I'm excited about all the lectures, but this is certainly very relevant to what's going on right now. So
Good to hear it. I think I'll mention this to Ruby when she comes on, but I'm trying to get privileges completed at RMC so then I could do consults for you and the gastros electronically, sort of in a continuous fashion. It's like what I'm doing around California and Nevada right now. I've got operational clinics in Sacramento, obviously San Jose, Fresno, Las Vegas, Reno, and I'll be adding Santa Rosa pretty soon. So a lot of it's outpatient, but I'm definitely trying to build an inpatient component to this consulting work. And then once the coronavirus is over, I'll be there a little bit more in person, if that makes sense.
yeah. Well, look forward to all the information you're able to share with us.
And I'm trying to check in because I'm not always keeping track of exactly what I've sent to who, but have I sent you and Ruby the different protocols or guidelines about different disease states?
Yes, we've received a lot of information from you. Haven't had a chance to look through everything, but I believe so. Yeah, we've received that as well.
Fantastic, because that'll help a lot. Not that I expect you all to absorb it in 1 week. It'll be probably 1 year. But we'll work through these talks, build them around the guidelines so you know what's in the guidelines, why it's there, what to think about, what the more simple take-home messages are too. So that's great. All right, so you've got those. We got a curriculum built out. Those are kind of the two foundational sides of this whole thing. So really good start. And let me work on getting my talk up. Do you have Ruby's mobile to see if you could text her?
Yeah, let me see what's going on with her. She might be trying to find a space or wrapping up a consult. So let me check in with her. Oh, I should just call her. Hey, Ruby. Hey, are you going to be able to join in on the lecture or? No, it can't. Well, she said it was going to be recorded. So, oh, you're rounding. Okay. All right. Dr. Gish was just wondering if you were going to join us. Okay, no problem. All right, bye. She's currently rounding. It's been high volume in the past few days, so.
No problem. We'll get this recorded and I'll probably set up just maybe a 15-minute debrief with her in a week or so, or when you all switch off service. That's a good reminder. I'll have Sarah set that up just so she watches it, then we can talk about any questions.
Okay.
All right, so what I'm going to do is I'm going to start the recording and then, well, it says it's recording right now. That's interesting. I don't know why it started that automatically. Okay, that's interesting. Guess that's what that little cloud and red dot means. All right, let me get to share screen and then we will post the slides. And let me get a little bit quieter. All right, so this first talk is in some ways very basic, but also very advanced. And I'm saying it's advanced because a lot of people don't follow the outline that we're going to talk about here. But in this outline, it really is evidence-based and it's experience-based on how you work up people for liver disease, how you work them up in steps. And since you're on the inpatient service, I'm going to focus a little bit more on the inpatient side of things than I usually do. But let's get to this. And this, of course, will be posted on the website. So the whole issue about who should be tested for liver disease, well, basically everybody comes into the hospital, especially everybody on your service, I'm sure has a liver panel. So that's a very important start. So you're going to have that screening test. And probably most of the patients have had some type of abdominal imaging because they're in the hospital on your service for an abdominal or GI event. So you kind of have a low bar in terms of making sure the tests are done. Now it's about how do you interpret those tests. That make sense?
Yep.
So a little bit further, this is a little bit more outpatient oriented, but what we tell people in primary care is that every person who has metabolic syndrome needs to be tested for liver disease. This is not quite in the guidelines yet, but diabetes, hypertension, hyperlipidemia, obesity, right? Those are the four anchors of the metabolic syndrome. The other thing that we've changed to recently in hepatitis C is just test every adult. But of course, you need to take a risk history for everybody. A lot of reasons. And also people with high risk need to have hepatitis C antibody or PCR testing every year regularly. So somebody might come into your inpatient service, say, oh, I was tested for hepatitis C. I was negative 5 years ago. Well, if they're in the hospital, they came through the ED, I would test their hepatitis C again if they were negative. Hepatitis B is still risk-based testing according to guidelines, but the Hepatitis B Foundation where I work thinks every adult should have a hepatitis B panel in their chart. Now, this is a lot to ask of you on the inpatient service because you have a lot of acute issues you're dealing with, but back to the ideal world, everybody's gonna have a liver panel. We're gonna know every patient's ABCs. Hepatitis A antibody total, hepatitis B triple panel, hepatitis C antibody. The guidelines right now were updated for all adults and all pregnancies for hepatitis C, but in the past it was birth cohort, all adults as we mentioned currently. Psychiatric disorders, you're gonna work them up for Wilson disease with a minimum of a ceruloplasmin. Lung disease and liver disease, alpha-1. Autoimmune disease, if you have cryptogenic liver disease, high enzymes, the first 6 tests, which we'll go over in a moment what those 6 are, 6 tests, 6 minutes, $60. Autoimmune disease is next in line in that phased A, B, C workup. Somebody's jaundice, you're gonna get a liver panel or more. Large liver on physical, need to look at their liver tests. Signs of cirrhosis, evaluate liver, chemistry, CBC, coagulation. Abnormal liver imaging, you're gonna really start this whole workup. Minimum of the first 6, and then we'll talk about what's next. Right upper quadrant pain, you're gonna get imaging and a liver panel, family history of liver disease, at least a liver panel, but probably hepatitis B and C, maybe alpha-1, maybe Wilson disease, because those are genetic. This is really important, Rita, Ruby, everybody else who'll be listening to this presentation. There's a difference between liver enzymes and liver function. So starting today, going forward, if you tell me liver function, you're telling somebody else liver function tests, you're gonna either mean bilirubin, albumin, or INR. AST, ALT, alkaline phosphatase, GGT are not liver function tests, they are liver enzymes. They have nothing to do with function or measuring function. Does this make sense?
Yep.
Other liver function tests include lactate, glucose, cholesterol, and this wonderful test called TAG or thromboelastography. I understand at RMC that there's 4 different TAG machines in different places in the hospital. But Rita, are you using TAG, thromboelastography, for any of your patients for coagulation assessment?
No, we have not. I personally have not ordered that study.
I'm going to propose one of our next 2 talks on this clinical series for the inpatient services is to have one on clotting and one on ICU care or acute liver injury. So I think these are very important because starting today, I want you to think TAG, not INR, on the liver patients. You're going to still get an INR because it's just reflexive. I can't get rid of it, even though I'd like to. But I would like you not to look at the INR. I really want you to look at this thromboelastogram. And we'll go into that a little bit today, but a lot within the next few weeks. Elevated liver enzymes. How high is the ALT? How high is the ALP phos? What's the ratio? ALT 2 to 3 times ALP phos. That's hepatocellular injury. Alkaline phosphatase, GGT greater than ALT or a multiple. That's cholestatic. And Rita, really need you and Ruby to be putting a GGT in every chart in every patient. The other thing I need you to do on every patient is to fractionate the bilirubin. Give me a direct, give me an indirect on every liver patient. This is very important for a variety of reasons, which we'll talk about. We'll talk about alkaline phosphatase in pregnancy, hyperparathyroidism, high AST in marathon runners. People with trauma, lots of exercise can have a high AST. Take a good history, itching, fatigue, right upper quadrant pain, arthralgias, myalgias, rash, fever, weight loss, and then do a symptom assessment of chronic liver disease. Have you had ascites? Have you had lower extremity edema? Have you had GI bleeding, mental confusion, memory problems, mood problems? What are the other medical problems? What's the family history? Unexplained lung disease, alpha-1, unexplained psychiatric liver disease, Wilson disease. Then you think about autoimmune and thyroid disease workup as you get into that second phase. First phase though, you're gonna think of travel, raw food, high-risk behavior, raw pork, also in this list. Medications, so I call this hilly, silly, dilly. Herbal, supplement, drug. Should also be called millie for medication. Take a thorough history. And anybody with acute liver injury has to have a blood alcohol in their chart and an acetaminophen blood level. It doesn't matter what questions you ask. Standard of care is to make sure you have blood levels of each. Does that make sense?
Yep.
I mean, I do care about your history, but you're still going to order the tests.
Right.
Supplements, herbs. Have you seen a Chinese medical doctor, a naturopath, an herbalist? You could get around this just in a few seconds. Supplements, bodybuilding agents, weight loss treatments. People who want to get bigger or smaller. So here's a couple options. And high dose vitamins, specifically vitamin A. Social history, it's not you drink too much because everybody says no. How much alcohol, how many servings, how many units, how big are the glasses that are there? Recent travel, blood transfusions, hemodialysis, work in a healthcare setting, how many tattoos, that's what you gotta think about these days, injected or snorted drugs. A lot of people who snorted drugs also injected drugs, but they don't want that in their medical record, or maybe they forgot. You're in the coastal region. Once we get into the rainy season, very high liver enzymes. You have to think about amanita mushroom ingestion, high risk sexual behavior, and were they a war veteran? Physical exam on all your patients, GI, liver. Look for spiders. How big is the liver? You have to percuss it. Give me a height. Not 3 fingers, not 2 fingers, but centimeters. Do you feel a spleen? How are the fingernails? How are the palms? Is there ascites? Is there edema? Are there collateral vessels? Is there muscle wasting? In men, hair loss, gynecomastia. Then you could look for other signs of other diseases, such as acanthosis nigricans, signs of thyroid disease, xanthoma, xanthal asthma, which may indicate an increased cholesterol level, and JVD. You're going to be looking at also the hepatojugular reflex. Repeat the tests, although in the hospital, you're probably going to have 2 tests on everybody. Not so important, but this is more important for an outpatient workup. Repeat 2, 3, 4 weeks. They might be dehydrated. They might have the flu. They might have been too much exercise. This is very, very common. This says 8.9% of the population have this high ALT over 45, but 45 is wrong. That's what the lab calls normal. Normal is not healthy. ALT, healthy, less than 20 for women, less than 30 for men. Have you heard these numbers, Rita?
Yes.
Fantastic. I'm sure you're there. Symptoms, acute, chronic, and then we talked about this pattern of ALT to ALK-Phos ratio. This is a nice compilation of different studies that said, what's the reason for an elevated ALT? Fatty liver. 11% said no apparent abnormalities, but I'm going to bet half of them have fatty liver at least. Hepatitis, alcoholic liver disease, metabolic diseases, other, Wilson, iron, alpha-1, all needs to be in the differential. But viral hepatitis is substantial. We used to think of alcohol as the #1 cause of liver disease. Right now, it's causing maybe 40% of end-stage liver disease. But remember, a lot of these patients are obese, so they have combined alcohol and fatty liver. We call that CASH, combined alcoholic steatohepatitis, or non-alcohol combined together. Take a good alcohol history, do a metabolic workup. So this is the 6 tests, 6 minutes, $60. Number 1, surface antigen for hepatitis B. Number 2, hepatitis C antibody. 3, iron saturation. Do not order a ferret. Alcohol, free, CAGE. Good history. Back to Millie, Hilly, Silly, Billy. Take a good history of over-the-counter preparations. And we already talked about the metabolic syndrome, but I'm going to add in here waist circumference is one of the top important vital signs. Now, this is what happens next. That first phase is workup is negative. Acute or chronic, you're going to think about most of these diseases. I will say that viral hepatitis A is never chronic. It's relapsing occasionally. Hepatitis E is almost never chronic, but it can be chronic in chemo, HIV, or transplant patients, but this is quite rare. As you know, we've changed the name from primary biliary cirrhosis to primary biliary cholangitis. This started back in 2013 at a meeting I was at in London. I requested a name change. I was laughed off the stage, but 2 weeks later, the name change was full speed ahead as everybody bought in. There's infiltrative disease, metastatic cancer, sarcoid, amyloid, delta, autoimmune. Still has to be primary. But remember, PBC is part of autoimmune, PSC is part of autoimmune. This is more classic autoimmune hepatitis. ANA, F-actin, quantitative IgG. Everybody with elevated liver tests gets abdominal ultrasound, Doppler, hepatic vein, portal vein, looking for Budd-Chiari, portal vein injury. Sinusoidal obstructive syndrome can happen after chemo in the setting of stem cell transplants, probably the most often. This goes into more detail about the workup of acute hepatitis, but look at this huge history that's on here. You have to really do all these tests before you're going to blame a drug or an herb or a supplement. This is what is needed. AST and ALT, hepatocyte, liver enzymes, not liver function tests. We've noticed or noted earlier about healthy levels. AST, though, comes not just from liver, but from a variety of muscle sources. And also, kidney doesn't have much muscle. Brain doesn't have much muscle, so this is being released from cells in general. You have to think about exercise, dehydration exercise, vigorous exercise, trauma. The AST is higher than the ALT, but 98% of the time, this is due to advanced liver disease and cirrhosis. Alkaline phosphatase is high in adolescence up until the adult age range. It can become high again in pregnancy in a woman, definitely high in children when they're born because they have huge, massive amounts of bone turnover. Cholestatic enzymes. My favorite is GGT, not alkaline phosphatase. A lot of reasons for that, experience, information I've read. GGT doesn't necessarily mean obstruction, but it can, just like alk-phos doesn't necessarily mean obstruction. It can. These indicate disruption in hepatocyte membrane function. I'll show you a little bit more data on that in a moment. I never do 5-nucleotidase anymore. That went out about 15 years ago. Now it's interesting. Heart, liver, or liver-heart axis. GGT is a predictor of cardiovascular events and mortality because the GGT is this surrogate for heart risk in people with liver disease and fatty liver, a marker of inflammation of the enzyme system being turned on. Bilirubin. Total bilirubin's messy because of Gilbert's, hemolysis, other things that are going on in cirrhotic patients, but the direct bilirubin is really your and my best friend, our best liver function test. Fractionate the bilirubin in every patient once their bilirubin is greater than 0.7. Direct bilirubin lists a little bit more information about that here. I just want to continue to emphasize this. It's the best cheap liver function. What is normal? I'm going to propose that a normal bilirubin total, which is direct plus indirect, should be well under 1 and 0.7 for direct. Sorry, 0.4 for direct, 0.3 to 0.4 for indirect. That makes a total of 7 for those patients. 0.7. Above 0.7, you should be fractionating the bilirubin. Albumin, another liver function test, but it can be low because of inflammation or kidney loss. Half-life that's there. Hang on just 1 second. I'm going to pause this. Someone keeps knocking on my door. I'm recording. Okay, we're back online. All right, so albumin can be low because of kidney loss. Inflammation can drive down albumin, such as HIV, heavy alcohol. So it's not a great liver function test. Direct bilirubin is best. Total bilirubin, maybe second best. Albumin matching, maybe in that second strata. INR is even worse. We'll talk about INR in a moment. Let's see if I can get this to go forward. INR is very messy. It's dependent on vitamin K factors. It's dependent on altitude, reagents. So the best liver function coagulation test, which matches direct bilirubin, is TEG. So Rita, I want you and Ruby to be, and everybody who's on the inpatient service who's listening to this recorded talk, to shift from INR focus to TEG focus. This is a TEG analyzer. Left is the machine. It holds on that little white area, a little cup that's got blood in it. It moves up on a little elevator. The pin with a disc goes into the cup of blood. Torsion wire holds steady. The cup is rotating, and it causes a pattern to be relayed to a computer, onto a screen, onto a piece of paper, onto a data output. It looks like this. So I'll show you more diagrams in a second, but that SP, that stem of this glass, just think of it like a wine glass, is dependent on the vitamin K dependent cofactors, which means fresh frozen plasma. Alpha angle, also called a K, is dependent on fibrinogen level and fibrinogen function. How much fibrinogen do you need to give? How much cryo you need to give a patient? MA is platelet function. We really don't have any other tests in the hospital that are going to tell you if platelets are working or not working or partially working, whether you need to give platelet transfusion or use one of our TPO agonists. And then finally, this is a very abnormal diagram, but there's a tail that goes out here. And this is a patient who's got fibrinolysis, who needs Amicar or one of the anti-fibrinolytic. So this test costs about $60. An INR costs $80. An INR is messy. The TEG is clean. So hopefully I'll convince you, Rita, that this is what you need to be ordering now on your patients. Let's go into a little bit more detail. I want you to look at the left side. It says hemorrhagic. You see that looks like a little champagne glass?
Yes.
Low clotting factors. Primarily, that person needs fresh frozen. Move down one. Very thin champagne glass. That patient needs platelets or a TPO agonist. The one that looks like a very steep angle coming off instead of a curve coming off the stem, you can relate back up to the top central where it says normal hemostasis. That person needs fibrinogen, needs cryoprecipitate. Now you can supplement this really the only really worthwhile test to supplement is a fibrinogen level. But even that can be messy because it's not necessarily telling you the functional fibrinogen, it's just giving you a number. Then finally, you see the one where there's fibrinolysis taking place. You're going to see that in a DIC setting or other setting. That person needs Amicar or an antifibrinolytic. I use this much less for hypercoagulable problems. But if you come up with a hypercoagulable curve, you need to do a hypercoagulable workup. And we'll be talking about how to do that workup in a little bit. Probably not much today, but in one of our other talks. Every cirrhotic patient, every day, needs to have a Child-Pugh score in their chart, in your note, and a MELD score. I'm assuming Rita, you and Ruby know this chart or box by heart.
Yeah, sure.
Carry it around with you. But why this chart is wrong is because what if a patient's got an INR of 1.6? That's profoundly abnormal. What if a liver disease, a cirrhotic patient has an albumin of 3.6 and an INR of 1.6 and a bilirubin of 1.8? That person's got liver decompensation. But they're going to be scored as a child's A5. Wrong, terrible mistake. So know the CTP score, but especially on the low end, know about these nuances because a total bilirubin should be less than 0.7, not 1 to 2. So this data was developed by 2 surgeons, Child Turcotte, and then Pugh came in with a modification. He had something about muscle wasting or something that they replaced, I think, with the INR. Every patient should have a MELD score. Now it's called the sodium MELD, and there's even a newer one that's called sodium MELD GRAIL, just to make things a little more complicated. But the MELD is still your base, 6 to 40. It can go up infinitely, but 6 to 40 is your functional range. And these calculations can all be done online in just a few seconds through the MD Calc website, plus there's apps. Every woman who's of childbearing age who comes in with liver injury needs to have a pregnancy test. Of course, you're going to do a hepatitis B triple panel in all these patients. Okay, so you got an abnormal ALT, elevated alk phos, elevated GGT, the liver shows fat. But what do you do from there? Well, you have to look at a couple of other things. What's the AST to ALT ratio? The AST is higher than the ALT, 98% of the time, they have cirrhosis. You may have heard this before, but this is really important. Just look at the chem panel. It tells you a lot. High MCV, very likely to be a heavy alcohol user. And if you're thinking alcohol, there's a new test called PEth, P-E-T-H. Have you heard of that, Rita?
No, I have not.
This will be an anchor test for you and your team starting today. PEth, phosphatidylethanol. It tells you how much alcohol a patient has consumed in the last 6 weeks.
Huh.
They may lie to you. They may forget. They may be in a coma. If they're in a coma, you get a blood alcohol level, but you're also going to order a PEth. This is Quest has it, LabCorp has it. If you have any trouble getting that done, you let me know. We will make it happen.
Okay.
You got a high alk phos that's substantially higher than ALT, you're definitely going to be thinking of PBC or PSC. We'll go to that a little bit later. Non-invasive testing, we're going to dig a little bit deeper here. So an ultrasound says, oh, fat, big liver, big spleen. Ask the radiologist every time, Rita, Ruby, to get a spleen height in centimeters, portal vein diameter in millimeters. Spleen over 12 centimeters, portal hypertension, need a scope. Portal vein over 12 millimeters, portal hypertension, they need a scope. APRI and FIB4 are online tests that are based on platelets and enzymes. Just plug those in on MD Calc, and it will tell you what their fibrosis level is. Take you 5 to 10 seconds each, much cheaper than a biopsy. There are blood tests called FibroSure, FibroTest, FibroSpect, which I never order. They're a couple $100. I think APRI, FIB4, what you're getting off an ultrasound, is equivalent or as good. They have fatty liver. You can do a NAFLD NAS score, and that will also tell you how much fibrosis they have in a very special setting of fatty liver. Non-invasive testing. Now, if the patient comes in, they got a big spleen, they got varices, they're GI bleeding, they have ascites, well, you really don't need to do one of these scores. But someone comes in, they don't have ascites, their bilirubin's 0.9, their platelet count's 120,000, you're going, they've got to have advanced fibrosis. So you're going to do an APRI, FIB4. If fatty liver, you'll do a NAFLD score. Cheap, meaning free. Okay, we've covered everything on this slide, I believe. There is a test coming out for the inpatient service at Regional Medical Center and hopefully many of the other hospitals where I work. Cook has designed a catheter that goes through an endoscopic ultrasound tube and can measure pressure in the portal vein and hepatic veins and give you a portal pressure gradient in just a few minutes. We're hoping to roll that out. I think you've heard about this, Rita. We're gonna have an orientation at the end of October on how to get this done. There's a lot going on in the hospital to make sure this gets paid for. It's not research, it's FDA approved, but there is some special teaching required for the endoscopy team, for the endoscopists. And of course, you all will need to know because these results are going to be coming back and you will need to know how to interpret them. We'll have a whole separate educational conference on that soon. Alcohol, we talked about. PEth, that's the upper one. You can actually get a urine PEth. You can do a hair analysis called an ethyl glucuronide, ETG. But the cheap way to do is, oh yeah, I drink some, but their MCV is 110. That's almost always alcohol. You'll check a B12 and folate, of course, but that 103, 105, 108 MCV really helps. This is the hair test. I won't go into that in any great detail. It's not a hospital-based test. Imaging, we talked about spleen size, portal vein diameter, how big is the left lobe, how big is this right lobe, how big is the caudate lobe, what's the liver texture, what's the texture of the liver surface. Doppler, is there flow in all three vessels? Artery, portal vein, hepatic vein. A little bit more on fatty liver. The new name, Rita and Ruby, is called MAFLD. You will hear me use that almost exclusively. Metabolic associated fatty liver. Diabetes, lipids, hypertension, waist circumference, BMI. We're trying to get away from non-alcohol because we don't want the word alcohol in this discussion until we bring back an alcohol history. So it might be alcohol plus MAFLD, and I call that CAFLD, combined alcohol, non-alcoholic fatty liver disease. We emphasize platelets here. So once the platelets are between 100 and 150, or really 100 and 170, they're F3. Platelet count under 100,000, they're F4. AST, ALT ratio between 0.8 and 1, F3. AST higher than ALT, F4. Look at all this that can be done, Rita, right? Ruby will confirm. No cost or minimal cost because you're already going to have an ultrasound. All right, we talked about platelets, APRI, FIB4, NAFLD ratio. This is just a slide summarizing this. Take some time, take a history, complete imaging, simple blood tests, physical exam. You will figure out the cause of liver disease in 99.9% of patients, including my phase 2 and phase 3 workup. Cryptogenic liver disease is almost unheard of. These are medications. that can cause a hepatocellular on the left, mixed pattern in the middle, cholestatic on the right. On the right, there's a number of other medicines that are just listed there by classifications. One thing that's very wrong about this slide is that statins don't cause liver disease. It's less than 1 in 100,000 patients. Put them on here so it's a talking point. Statins are liver protective. Lower mortality, less portal hypertension, less cancer of the liver. Everything else on here is factual. Drug-induced liver injury, dilly, hilly, silly, milly. Take a good, thorough history. Acetaminophen. Every patient with acute liver injury or unexplained chronic with high liver tests, you need to get an acetaminophen level in the chart, blood test. Toxicity is 6 to 12 grams a day, but you can have liver toxicity at lower levels of alcohol use, fasting, intercurrent illness. 2 to 3 grams is the threshold. Okay, so we talked about the first 6. Now we're moving to phase 2 into a little bit more detail because autoimmune hepatitis is quite common in terms of inpatient acute hepatitis. When you're looking at a chem panel, always look at the globulins. The globulins over 3.5. Something's going on with the immune system, an overactive immune system. Classic autoimmune hepatitis, very high AST and ALT. PBC, much higher ALK phos, GGT than enzymes. Same thing for PSC. So if you have a man with an ALK phos of 300, enzymes in the 60 range, go to an MRCP. If you have a woman with an ALK phos of 300, elevated GGT of say 150, enzymes in the in the 80, 60 range, you're going to order an AMA first. But you're going to cross over. MRCP is negative in a man, order an AMA. Men do get PBC. Vice versa. A woman has a negative AMA, you're going to think about getting an MRCP or a liver biopsy to look for primary biliary cholangitis. Liver biopsies, Rita, Ruby. Your radiologist has to do them all with 16 gauge needles. If you get any pushback, we only do 18. We only have 18s. Contact me. I will convince them using the guidelines that 16 gauge, 2 passes is standard of care. Hemochromatosis never causes acute liver injury in adults, but it can be a cause of chronic liver injury. That's why you get an iron sat. Alcohol, alcoholic liver disease we talked about. Liver enzymes are very rarely, AST, very rarely over 300. You see an AST over 300, it could be alcohol plus something else. And if you see an AST and ALT of 10,000, it's almost always alcohol plus acetaminophen. Occasionally shock liver. Fatty liver, we're going to have a whole separate discussion on. Very, very common. Alpha-1 Wilson disease. Alpha-1, never acute. Wilson disease can easily present as acute liver disease. You're thinking Wilson disease, you have to do 3 tests. Ceruloplasmin, 24-hour urine copper, liver biopsy for quantitative copper. So, elevated liver enzymes. Do a full H&P, a full workup. Look at their function tests in combination with liver enzymes. Stop all unnecessary medicines, stop alcohol, recheck in 2 to 4 weeks. This is again an outpatient workup. Inpatient, you'll have a recheck of the enzymes the next day. And if the liver tests remain abnormal, you're going to do the 6 tests, 6 minutes, $60. You're going to think about this PET test we talked about also. You're going to look at the globulins. Globulins are elevated. You're going to move quickly to doing an autoimmune workup. First with a smooth muscle and ANA, but potentially an AMA, ANCA, and other special testing. Acute liver disease, a little bit separate issue, but more common in the hospital setting. Every patient gets a hepatitis A IgM. Every patient gets a hepatitis E as an elephant IgM. Hepatitis B panel for acute is different than chronic. The acute panel, you need a core IgM. Unfortunately, the labs, maybe in the hospital setting is better, but they always do core IgM. In the outpatient setting, it's nearly worthless. Let's see, I think we've covered everything else on here. We've covered the 6-6. That's again, just a repeat here. Do you have any questions on this 6-6, Rita?
No, I did want to just go back to path. Which is more reliable, blood or urine?
Blood. Blood path is my recommendation.
Okay.
Great question. Every patient with high liver test gets a Doppler ultrasound, spleen size, portal vein diameter. There's some other tests to think about. That's the simple message here. Surveillance, you got a COVID patient coming into the hospital. You have to basically go through the entire same workup. SARS-CoV-2 virus can cause elevated liver tests, but it's only 3 to 7%. And it's extremely rare that it would cause or contribute to liver failure. But it does infect the liver. We have these ACE2 receptors in the biliary tract. So the virus gets into the liver, infects liver cells, especially biliary cells. This is that number. Patients with acute liver injury, AST, ALT, greater than 15 times upper limits of normal. Let's just say that's 30 for upper limits of normal. Getting into the 3 to 500 range is less than 2%. These are patients who developed acute liver injury, these high liver enzymes. Very, very large number of patients who got out of the hospital without any problem. There were a few patients that did die, and it looked like hypertension. It's interesting that non-hypertensive patients had a higher mortality rate. They weren't dying of liver failure. So that's a wrap. What did we miss?
I think you covered everything.
I'm gonna stop
So,
recording.